All right, good afternoon, everybody. If we could get started. I know a few people are trickling in, but I want to make sure we don't shortchange our time here. At this point, most of you probably know me. I'm Nelson Repenning. I'm the faculty director for the Leadership Center and the Associate Dean for Leadership. And it's my pleasure to host iLead today. And we are very pleased to welcome Sandra Fenwick, who is the Chief Executive Officer of Boston Children's Hospital. It's an organization that is 20,000 strong and was ranked by U.S. News & World Report as the leading pediatric provider in the country. She's been at Children's since 1999, where she started as Senior Vice President for Business Development, quickly moved to be Chief Operating Officer, and then became President in 2008 and has been the Chief Executive Officer since 2013. Prior to that, she had a bunch of different roles at Beth Israel, another local medical institution. We are very pleased to have Sandy here, and I actually, as I told her earlier, lobbied hard to be the host for this setting because there were two big thank yous that I wanted to express to her and her organization publicly. Number one, having raised two children in the area, we have been regular consumers of your services, particularly the emergency department. All has ended well, thanks to the good work. And then also, I know there's a bunch of EMBA students here. Children's has sent us a fabulous set of EMBAs over the years. And so we're extremely appreciative of all the great students, and we hope you send us a bunch more, because they've added a lot to our classroom. So format today is, again, you're probably familiar with, fireside chat. I'm going to ask a few questions to get us warmed up. And probably, between a third and halfway through, we will turn it over to you all. So start thinking of the questions that you want to ask. Okay? Oop, careful. So, Sandy, welcome. Thank you very much. So, for our first question, we typically like to start with context. So just give us a little sense of your career path that got you to the, at least metaphorically speaking, the corner office of Chief Executive Officer.
Right. Well, thank you, and thank you for being here, and thank you for a full room. I was hoping, I was afraid we would have a whole bunch of empty seats. So, I like to think of a career and life as sort of a mosaic, or a combination of a whole bunch of twists and turns, and that certainly has been mine. I knew I wanted to be in healthcare and science since I was probably 11. Great science teachers and great opportunity. So I started in college with a degree in biology, chemistry, and I was pre-med on my way to medical school. I never got to medical school, as you probably know. And that was because I spent some time in science and in research. First out of college at School of Public Health at Harvard, and went for 2 years to Saudi Arabia with them. And that was a great life experience. I was doing both clinical work, some clinical epidemiology, and a little bit of bench research. And it was an opportunity to sort of see it all. And after that, a couple of years in science again down in Texas at MD Anderson, and realized that both the clinical and the science were probably two not areas that I really wanted to pursue as a career. Couldn't see myself sitting at a lab bench for my life, and working with patients is a real gift and something that I absolutely admire and respect. And so started very much right after that, after getting my master's in public health, epidemiology, and hospital administration, to really just start as a manager. And being curious about how hospitals run, how operations run, how the clinical operations run, how science really gets done in an academic setting, really just took me on a journey all the way through the hospital, across almost every department, inside, outside, and ended up where I am. Lots of opportunities.
Yeah, fabulous. So you lead a large, really complicated organization staffed by lots of smart, talented people. Are there one or two approaches to your role as a leader that you think stand out, or that your go-to activities? And if you could tell us a little bit about how you came by those, that'd probably also be helpful.
Sure. So, when I think about both what I bring to the game and what I look for in others that I bring together around me as a team, I think first and foremost, sort of starting with passion for what you do. I have always thought of myself more as a servant leader because I'm not a clinician, I'm not a scientist, I'm not someone who really is in the depths of working hands-on with either patients or doing the science. I see myself as enabling that. And so a passion for what others do and how to support them is, I think, first and foremost. And that's what I look for in other people. And I think then there are the personal characteristics of integrity, honesty, trustworthiness, the ability to be open, communicate, is something that, I think I both try to bring to the game, but I also look for in others. The ability to take risk and have courage to take risk, because at every step of the way, whether you're a manager at the beginning of a career or anywhere along that way, having the ability or having the courage to take on something big, something challenging, making choices, asking for, not for permission, but to be able to do the kind of things that you do is I think, really important. And then having some kind of vision for what you really want your program, your department, your team, as you get larger, your institution, and knowing where you want to take something, how you can be actually better at what you're doing as an organization. How do you continue to perfect it? How do you continue to lead, and then figure out a way to get there? So those are sort of principles that I've looked at, both in terms of the way I like to lead, bringing a team together that brings all those characteristics and character to the game, and then figuring out how to orchestrate that moving forward.
So if you'd allow me a follow-on, given the size of your organization, do you have any ways that you try to stay connected with the sort of rank and file, the people who are doing the work every day, given that, obviously there's way more of them than there are of you?
It's a challenge, and it's probably the best part of my day. So I absolutely love meeting with faculty. I love being in the labs. Last Friday, I spent 2 hours with one of our sort of mid-career faculty and just wanted to be down in the zebrafish lab and watching what was going on in her lab, and really understanding what her team was working on, what their goals were. I love going up on the units. I do walk-rounds every other week, high reliability walk-rounds around patient safety. We pick a unit, we pick a department, a clinic, and we go and meet with faculty. I love getting in front of departments and doing this as a team, or I've been trying every year to get around to every department, every division, and use it more as an interaction as opposed to I go and bring slides or something. Those are the best parts of my day, and I wish I could do it more.
So as we were getting ready for today, we talked a little bit about some of the new challenges that a leader of any organization is facing in the current environment. Can you talk a little bit about what are some of the biggest challenges that you face as the Chief Executive Officer?
So as we were talking before we came in, I think every day is a challenge, whether it's something that has occurred from outside in or is created because we have some kind of challenge inside. And as we were talking, I think one of the biggest challenges we all have as leaders is, as I say many times, this job would be easy if it weren't for the people. Because the challenging issues of managing people, managing expectations, working with really high-performing, passionate people who either want more and there aren't opportunities to give everyone more, who have resource needs, who have great ideas and want to bring forward their ideas, and you can't do everything, so you have to say no. Working with people that are behavioral challenges or inappropriate, and how you work to either try and get them back in line or move them out. Defining high-performing and non-performing. What do you do when you have a non-performer? How fast do you move on putting them either into the right role or not in the institution? If I look at what are the challenges? Those are the ones that I think are the toughest for anyone at any level, whether you're a manager of 3 people or you're managing the highest level performing people in your organization.
So just as a follow-on to that, I think often one of the most challenging sort of HR issues is a high performer that may not sort of live up to the values and norms of your organization. I imagine that's happened at least once or twice in your career. How do you tackle those?
So, I think initially, especially if it's someone who has been providing at least an enormous amount of value to a department, to a team, to the institution, you first and foremost try and figure out if there's a way to work with them, to get them to understand and be more self-aware of what they're doing. Many times they're not, and so helping guide them to greater self-awareness and giving them tools and approaches, whether that's with a coach, whether it's with counseling them yourself, or just providing a forum. When that doesn't work, you got to move. And I think you realize over time that it creates a poison to some extent within the institution, and you have to make a decision to move. And sometimes it's the one that is the hardest one to move because they're rainmakers, they're leaders, they're brilliant, they're geniuses, but then you just have to have the courage to make that decision.
Gotcha, great. As you think about your role as a leader and the different tools and strategies you use, are there places that you're currently focused on where areas you think you could continue to get better? I mean, obviously you're very good, but areas for improvement.
Oh, yeah, absolutely. I could give you probably a chapter. I don't know if anybody knows Frances Hasselbein, but I think she's 103 or 104 now. She was the original founder of the Girl Scouts of America. And I was listening to her talk the other day, and what she said is, one of the things we all need to do as leaders is listen more and speak less. Be the first to listen and be the last to speak. And I think that's always the hard thing, especially when you've had a lot of experience and you've been there, done that, and seen it before, is to allow for the dialogue and the input and the discussion that others really want to bring when you bring a team together. And so listening and then speaking. But then I think we all have to be the ones that call the question and finally kind of bring it to closure and make a decision. But I think that listening part is something that, listening and patience are 2 things that I continue to work on, having more of each.
Is there anything in your tenure as the CEO that you're most proud of in your time at Children's?
Oh, I think it's the impact this hospital's had, and that's not me. I think bringing together the people and giving them the ability to experiment in a safe and obviously compliant and careful way, to bring their innovations and their ideas forward, to constantly be dissatisfied with the status quo, whether that's not having the knowledge, the tools, the devices, the technology to take care of patients that come to us now literally from all over the world. Coming with unanswered questions, untreatable diseases, and to have people spend literally their entire careers working on these solutions and caring for these kids, and making a difference not just for each child, but then disseminating that knowledge and not being afraid to give it away. And where I struggle with that is how do we make sure we don't give everything away? Because there's a value there that, to some extent we need to recapture, but we also need to be the place that really disseminates it and brings it out to the rest of the world. And boy, I tell you, all of us who are at Children's have truly the best jobs in the world.
That's great. So shifting gears slightly, although you provided me a nice segue, obviously technology is a big deal here at the Institute broadly, and particularly at Sloan, we think a lot about how new technologies are going to change the way that organizations are structured, industries are structured. I know your industry is one that's going to see a huge flux of new technology in the next decade or so. What's happening with that at Children's right now, and how do you see your industry evolving thanks to new technology?
About 10 years ago, we decided that we had clearly been leaders in basic science, in really the discovery science, and bringing that, which we then said we also need to find a pathway to bring that more to patients faster. So bringing together a translation and then clinical program was a journey that we started more than 10 years ago. But at the same time, we also said there are so many people at Children's that have ideas for how to incorporate technology, to embrace the digital world. And how do we give them the platform, the opportunity, and maybe the assistance to really take their ideas and take them somewhere. So we started with a chief innovation officer that we brought on board, and I think we were one of the first hospitals to put one of them in place. And that was what we did. We kind of opened that up and said, let's create fora for people to come together to bring their ideas and then to give them either tiny little grants, $10,000 grants, or a software developer to work with them for a very limited sort of sprint to give them the opportunity to test their idea. And that was sort of the beginning of it. This has evolved. That person left to go off and be a chief innovation officer someplace else. And we brought on another chief innovation officer whose background was really very deeply in the digital and technology space. And he has just exploded that. And so we've looked at this as to what do we do internally to make the lives of our, sort of create a digital front door for our patients, whether that's virtual visits, whether it's the use of voice. It is allowing them the opportunity to interface with us through our portal, building that whole digital front door, and have a lot of people working on that. We've also looked at how do we enable our clinicians with tools, with building their own apps, giving them the opportunity to be more facile with caring for the patients that they see. And then we looked at our administrative infrastructure, and were there ways that we could actually use bots and things like that to really improve the efficiency and effectiveness of our administrative systems. So that was the inside piece. And then we've built what we call our Innovation and Digital Health Accelerator. And there we have a whole team of people who are working with partners on the outside, either helping new startups in this space or big players like Verily or GE, and wondering whether there are opportunities for us to be advisors to them, develop content with them, give them opportunities to pilot some of their things inside a setting, a clinical setting, sometimes specifically for children and sometimes just in a clinical environment. So that has just exploded. We have probably 75 people in that space right now, just dedicated, mostly software engineers, developers, business developers that are all working in this space. And many of them are just kind of getting into the space. Some are experienced and this is their first career. And it's really exciting.
So as actually a follow-on, that seems like a remarkable achievement because Children's has obviously been wildly successful, and success does occasionally breed insularity. So as the senior leader of the organization, how have you helped break down the idea that there might be ideas outside the four walls of Children's that could actually be valuable to your organization?
So we're not without our insular approach and think that everything has to be invented at Children's. But we have, I think, been absolutely doing this both inside the organization in clinical teams that are really now cross-departmental. We now have probably 25 centers that are all multidisciplinary. So you have to start inside before you can say, well, let's bring everybody into our little narrow silos. Trying to break down those silos first has been both in the research side, the technology side, as well as on the clinical side. And increasingly figuring out how do you do that outside and how do you cross that bridge. We started something with really two other competitors in our genomics, and we call it our Genomics Research and Innovation Network. So Cincinnati Children's Hospital, Children's Hospital Philadelphia, two big competitors to us in many respects, we decided, the three of us, to pool our assets, particularly around children with rare diseases. And so how do we build a lot of the infrastructure, the data analytics, the tools that we need to get consents, and streamline that so that we can all benefit from it, and then pick a couple of areas and work on it together. So that's been very instructive, and it was a model that has only exploded, and now we've just gotten a $9 million grant for the three of us together. So it has really leveraged, I think, a lot of opportunity, and we can replay that over and over again.
Oh, fabulous. Let me ask one more, and then I'll turn it over to the audience. I'm sure we have several folks here today that are interested in careers in the medical space, broadly construed, whether it's hospital administration, working in bio and life sciences, or devices. What advice would you give to Sloan students that might be interested in a career in that area?
Well, we are constantly looking for talent in every one of these areas. And I think of, what are some of the things that people really need to bring? We talked about some of the characteristics, real interest in not just passion, not just, bringing technical content skills. I think finance is, we didn't talk about that earlier, but I think having an understanding of how things really work from a financial standpoint, just enough of an understanding so you have some sense of the implications of whatever you're working on. And then I think the people skills that we talked about earlier, how to work in teams, how to be a leader and a follower in coming to the game and with your great idea and bringing a whole group behind you and finding ways to bring followers to the game and lead, but also be a follower when someone has a great idea and you are being asked to come in and bring your expertise to that game. I think this is an area that no matter where you start is absolutely going to explode across every one of the domains. We're struggling, when you asked about technology, we're struggling with the EHR. So if anybody wants to take that one on, we would welcome your both your involvement and your expertise, because that's an area that is just an incredible burden. So there's lots and lots of opportunities.
Great. All right, why don't we open up to questions? Questions for our speaker? Yep, go ahead.
Yes.
If you don't mind waiting for the microphone, it's on its way.
Hi, and thank you for coming to speak with us. So I was looking at the sort of the list of the board of trustees, and it's like a long list, and it's sort of reflected in the size of the organization. It had me wondering about the process that underlies vision setting or establishing sort of priorities. So as a senior leader of Boston Children's, I was wondering if you could walk us through a little bit, sort of how the discussions take place for determining sort of where to go and what to say yes to and what to say no to.
Okay, sure. So, you start with, where do you see the goal, the vision of the organization? And we start with the fact that we see ourselves as having been leaders in both care and discovery of new solutions to deliver care. So it has a care component and a science and translation of that science component and innovation in that area. And so it's not just basic science, but it's innovation across all domains, including technology. So we see those as two of the strategic pillars of the institution and how we're going to continue to lead in that. And then the question is, so from that, what are the component parts that really need to support that? What people do we need? What infrastructure do we need? What facilities do we need? What tools and infrastructure overall needs to support that? And so we then, from that, on the clinical side, for instance, we look at where do we have strength in all of our clinical areas? How do we continue to support that, maintain it? Where do we need to ask the leaders of those departments to continue to push the boundaries of whatever their field is? On the research side, it's the same thing. Where do we have programs? Where do we need to recruit and retain the very best people? How do we make choices of how many different places we can actually be? How do we go deep, not just sprinkle our resources across many, many different areas? And then what are the tools that those people need to be able to do their jobs, and what resources, what financial resources, what support systems, what infrastructure technology like research computing within the research area, what technical expertise do they need to support them, and the like. So it comes down to starting with your purpose. We're here for the children, ultimately. That is our goal. We're trying to stay narrow in that field, although the implications for what we do spread out broadly to the adult world as well, based on what we deliver in care and what we identify in discovery area. But then everything tends to flow from that. We do that at the senior executive level. We bring in the clinical and scientific leaders to that process. We then bring it to our board, and we have discussion and retreats once a year with our board that specializes only in strategy development. And then we break into sessions, and are we doing enough in this area? Are we doing enough in that area? Have we put enough resources into this one? Is it imbalanced, or should it be imbalanced? And then we bring it out. We put annual goals out there. We put metrics to measure those goals. Every one of us, we as leaders, have goals for the whole, but all our leaders have individual goals. Our chiefs have goals. Our scientific leaders have goals. And then we track them, and we bring them back to the board on a quarterly basis. So is that what you were asking?
Right in the center here.
Hi, thanks a lot for doing that. I'm Jim Rathmel. I'm up across the street at Brigham. And my question for you is, given the healthcare environment in Massachusetts, highly regulated, and the bad reputation that both Partners hospitals and Children's have gotten for being very, very expensive, what's your strategy going forward? Do you think either your institution or Partners is going to be able to deliver care at competitive rates in Massachusetts, or are we going to be taking care of the rest of the world and Massachusetts residents will get their care other places? What do you think is going to happen?
That's a good question. We've been in the midst of this for more than a decade. So when the new healthcare reform law took effect now almost a decade ago, I think we felt that pressure already upon us. And I think both Children's, I think the Partners institutions, took that very seriously. We worked very hard, especially at Children's, because we were so much smaller, and I think we felt the pressure and the threat even greater than perhaps the larger systems did, because scale was not on our side. We had to dive deep into cost reduction, and we took a lot of cost out of the system, looking at both unit cost as well as looking at utilization, and really trying to say, what's the right care for patients at the right time in the right setting? And when is it right for children to come to Children's? And when is it right for us to partner with others to deliver care? And so I think all of us started to look at, do we need to take care of every child, and sort of say, build it and they will come only to us? And I don't think any of us said that was the right idea. So we have all built distributed systems. Children's doesn't do it all ourselves. We partner with Partners. We partner with the other systems here to deliver care broadly, so that we are enabling care to be delivered in the right setting, the more cost-effective setting, but also the lower intensity setting. We're doing that now, and Partners has done that clearly with building urgent care centers. We're not building them, we're partnering with them. We deliver care in emergency rooms in community hospitals that we do not own. We do not own our primary care network. We partner with our primary care network. We're doing this now with regional hospitals all over New England. And we're sending, just like some of our partners and others, enabling others to deliver not just routine care, but specialty care in Hasbro, in Rhode Island, and Barbara Bush up in Portland. So we're finding ways. We've had to change a lot the way we've thought about delivering care, that everything shouldn't be build it and everything will come to the sort of the mothership. So I think we have been mindful about the pressures of cost, both what we deliver in our own institutions, but also how to deliver care broadly, how much we do in community settings, in schools, in community health centers. And I think that that's been a journey that we've all been on and have to stay on over the next decades. We need to think about what are the contributors to bad health and how we embrace some of those things. How do we support looking at social determinants of health, the issues of food and nutrition and violence and behavioral health, and do more of that in the community setting so that patients don't end up with us. And I think we have to think about all those components, and then also think about the fact that we do need scale. And so we need to be a destination for those kids that are going to come from around the world and around the country, for the scale requirements of the academic medical centers that we want to continue to be. So I think we've got to do both at the same time. I don't know if I answered your question or not. Close.
Yeah, let's go right over here.
Thank you very much for your presentation. Anatol Melny-Hansen from the UK. I work at Guy's and St Thomas's, NHS Foundation Trusts, and Brooke, a young person's charity. My question really was about your leadership out in the community, and you've partially answered that with schools. And I was thinking about obesity in young people and how do we, preempt them being ill, needing your services. But the other thing was about engaging with young people and getting their voice. And how do you engage with the young person and parents and make sure that you're responding to their needs?
To the needs of the parents and the children.
And the young people, yes.
So, a good question. We like to think of ourselves as what we do is provide complete family-centered care and embrace the family in virtually every aspect of what we do. That's before the patients get here. So what are we doing in our primary care setting to enable families and parents to care for their children in their home, at the schools, and the like? When patients actually come to us, the families are absolutely a part of what we call the total care team. That's true in the clinic setting. It's true in the inpatient setting. Families join rounds when we do rounds, and I think we've got clinicians here who have had families join rounds so that their input into how they're experiencing their child's development and their child's progress is incorporated into the plan. They are absolutely, increasingly, when they come to the hospital, instructed how important their role is as a caregiver in the process of, having eyes on their child when we're not in the room, alerting us when they believe their child is actually going in the wrong direction, raising concerns that they have about communication, information, and then ensuring that they have what they need when they leave. Increasingly trying to connect them remotely. So one of the things we've been experimenting with in our cardiac surgical program is the potential to use Alexa voice to actually connect with patients after surgery, it's called Enhanced Recovery After Surgery. It's an experiment, a kind of a pilot that we're doing to actually allow families to use Alexa to really connect with their portal and really provide information from the home to their clinicians in a very structured format that really makes them feel as though they can really connect on a real-time way with their clinicians. So we're trying different ways, how to use technology, how to use the portal, so that the parents have every aspect, all of their information. I was talking to one of my colleagues who said they were sitting in the emergency room at one of our institutions, not ours, but they were sitting in the emergency room and they got the lab results through the portal on themselves faster than the doctor could come in and give them their results. So there's a lot that is really, really a way of we're connecting with patients, families, and the like. We have a center for families that we embrace the families to come in. We can connect them with their physicians, especially if they're coming in from a distance, and do a consult before they leave virtually, so that we're actually doing the handoff virtually through our Center for Families, connecting a virtual visit with the connecting physician on the receiving side before the patient even leaves us. So we're trying a whole host of ways of really making those connections and those handoffs really work.
Yeah, go ahead.
Thank you for a great talk. Thinking about profitability as a CEO, I guess my question, and inspired by what's happening in our kind of political debates recently, how do you see like any tension between a hospital for children making profit? I mean, from like, I guess, a moral standpoint, like making profit off children in need of healthcare.
So we don't call it a profit. We call it income, because it gets 100% funneled back in to the investment in what we're doing. And we desperately need that to continue to make investments, because if you think about how we're structured as a nonprofit institution, we have clinical revenues where there is the potential for profit. We have a research mission, an education mission, and a community mission. The latter three missions all require annual investments just to continue to keep those running, not even future strategic investments. And so the clinical income, profit, supports those other missions. But even on the clinical side, most of us in both the adult and the pediatric world, especially in this country, have a disproportionate number of patients that we care for through the Medicaid program, which is the program largely now for children, and it covers about 50% of the kids in this country. We lose about 40 cents on the dollar of cost on every child we see. So, and the doctors, that's the hospital, the doctors lose probably 10 or 15%, 20% more than that. And so it has to be made up by the commercial payers on the other side to just balance the clinical income side, as well as the mission. So it's a very complicated sort of business structure. And so one profit really supports all the other things that really we don't make any income out of. But at the bottom line of all of this, the only way we can continue to invest, whether it's in the research or in new people, new recruitments, new buildings, is to have a margin on an annual basis, because the alternative is we would have to absolutely depend on philanthropy. And that would never be sufficient. Even though we raise a lot of money through fundraising and donors, it would not be sufficient for what we need to do to invest.
Great. Yeah, go ahead. I'm in the far right there.
Thank you. So I was wondering, what do you think sort of the Boston Children's Hospital of the future will or should look like, and what is sort of the biggest difference with what it is today?
Well, we've been around for 150 years this past year. And we have been leaders in both advancing care for children. That goes back now literally decades. Firsts in many, many different, culturing the polio virus that led to the polio vaccine, the measles virus that led to the measles vaccine, the first heart procedure in a child that led to the whole field of cardiac surgery in children. And it goes on and on and on. And so that is something that I want to see us continue to do, to solve the unsolvable, to understand more the genetic cause of disease, especially for rare diseases. So the science and the care advancement is what I believe our responsibility and our role is today and in the future. So I'd like to see as much, if not more of it, because I think that is our leadership role in pediatrics. While we are always going to be a community hospital for this community and a resource for the people who live in Boston and Massachusetts, I think our real responsibility is to continue to advance care, knowledge, and understanding and the well-being of children, both here and our spread of knowledge broadly.
Over on the left here. Yep.
Thank you. I'd like to hear about your experience as the first female CEO at Boston Children's Hospital. So what kind of challenges do you see female leaders in healthcare field, and what kind of inspiring experience you could share with us? Thank you.
So I have been very fortunate and blessed in many respects to have been in work and relationships, both my previous work for 20 years at Beth Israel with incredible leaders, and both on the administrative, both on the clinical and research side, here at Boston Children's within the Harvard medical system, and both with mentors and partners. Both my previous CEO, we were partners for 13 years and had just an extraordinary relationship, and working together where we complemented each other. He was a physician, I'm not, and we found a way of really adding value to each other and to the institution working together. I now have a partner, since I'm not a physician. When I became CEO, I decided to create my partnership role with another physician, and we are partners, and we work very hand in hand. And I think that kind of finding where you have both expertise and strength, and where you have not expertise and where you need to be complemented, and then finding people who provide that to you. We two run the organization together. We talk every single day, all the time. We think sometimes sometimes differently, but we are here as the servant leaders for the institution and the best interest in the institution. And I think that's really what leaders going forward really need to be thinking about. What they bring, what they don't bring, and how to replace that or add to it by either a one-on-one partner or a whole team around you. Because boy, I could never do this job without the rest of my team. Whether it is the expert in finance, the expert in law, the expert in government relations, fundraising, investments, I mean, you name it. So I surround myself deeply and broadly with expertise, both clinically, scientifically, and from every aspect of running the organization. I don't know if I answered your question, but.
How about right here? You've had your hand up a few times.
Thank you so much for spending the time with us. I just wanted to go back to your closing remark about the challenges you face with your EHR system. Could you elaborate a little more on those, and maybe what advice you would give to anybody or any other organization trying to build an alternative?
As we were one of the first places in the industry to try and bring in EHR into the clinical setting. That goes back now probably 17, 18 years. When Cerner was really the only option out there for an inpatient, complex, pediatric-only environment. And they were very willing to work with us to try and bring that into the system. Subsequent to that, others have entered the field, and others have brought different areas of expertise. Epic, for instance, has a very robust revenue cycle. And so we're a system that's a split system right now. We have Cerner on the clinical side, we have Epic on the doctor side and on the revenue cycle side. And so it's pretty complex of having two big systems that are trying to constantly interface. Not very efficient, some redundant, probably more costly. But we don't have a perfect solution out there. What I would love to see, and what we're working with a startup company called Commure that is trying to build a platform of interoperability. We're trying to be really an alpha site with them to see whether there's an opportunity to take both the big systems and a lot of the smaller systems that we have, because we have a lot of applications of other systems that we're also interfacing, and a lot of simple one-off apps that we're trying to bring to the clinicians, and trying to see if there is a way to create this platform that creates the pipes that allows for all of this to work at the institutional level, but also across all of these complex interfaces that are very complicated. I think at one point we had over 120 connections that we were making with different applications, trying to bring them into our system. Every time you want to make a change, you have to be mindful that all of those are going to, be adapted to create that. So that is one goal that I think we would absolutely love to see. And at the federal level, this whole debate now about interoperability and providing the data and the access to all of these systems is something that I think we believe strongly in. And I know we've got resistance from some of the systems that don't want to go in, but we believe that that really is the long-term solution to this problem. Right now, the burden on the physicians and the nurses and all the clinicians is just so overwhelming. And we're not able to extract out the information that we need to really understand what's that gold mine of data that's sitting in those records. It's basically taking the paper and putting it online. It really hasn't done a whole lot more than that. And with regulation and requirement for so much more data, it has become an overwhelming dissatisfier and burden to our clinicians. And that's got to get fixed, because I think that that probably is the thing we hear the most from all of our clinicians.
All right, probably have time for one more. Let's go to the left there. You've had your hand up a few times. Yeah, go ahead.
You mentioned earlier the importance of choosing metrics in order to measure your goals and success, and children's gets measured against other hospitals as well. Can you talk a little bit about the process and challenges in choosing the right metrics? And has there ever been a time when you realized that you were measuring the wrong thing or potentially driving incorrect behavior, wrong metric?
Oh, that's a good question. There are always challenges first of all, you can never have so many metrics that you got a dashboard that's, either unreadable or pages and pages and pages, because you then get lost in what's the data telling you. So trying to pick a few number that really are giving you direction and guidance, I think is critically important. But there are times, especially when we've been doing things, for instance, in the area of efficiency, where we're trying to drive down, give you an example, length of stay. So we're trying to say one metric of driving improvement is to squeeze patients' length of stay. But you always need another one to look at to say, what's your readmission metric? And have you squeezed so far that that one is going to go up? As this one goes down, that one's going up. And you've got a problem because you're probably creating disincentives or the wrong incentives to push people out too fast. And you're seeing the countervailing metric that's going in the wrong direction. So I think you always have to look at what are you looking at, and where can you see that the behavior that you're trying to drive is actually creating the wrong impact or the wrong effect. That was one that I think a lot of people have used as an example, but there's lots of other ones that I think we always have to have, ones that look at, if you push too hard or too far, are you creating wrong behaviors and wrong incentives?
All right, we are going to start to lose people as they go off to class. Sandy, thank you very much. It's been fabulous having you. We really appreciate you taking the time.